Hi, my name is Kirk, your host of the Staying Healthy Today show. This is a show where we bring you key experts in the fields of nutrition, prevention, integrative, and lifestyle medicine. Today's show topic is the value of coronary calcium scoring as the best assessment for early detection of coronary artery disease. My guest today is Dr. Matthew Budoff. Dr. Budoff is a cardiologist at UCLA, the David Geffen School of Medicine, a professor of medicine there. He is the director of cardiac CT. He is the director of the fellowship program in cardiology, and is also the medical director of the Diagnostic and Wellness Center, which has a machine, a 256 slice machine that does coronary calcium scoring and also CT angiography. And there's other non-invasive testing done at this facility for cardiovascular disease. And it's a place where I actually spend my Wednesdays. I go there and do some wellness counseling when people come out of the CT scanner on lifestyle approaches to preventing and reversing coronary artery disease. But I got a real education listening and interviewing Dr. Budoff on why he is so in favor of this type of technology in the early prevention of heart disease. And here's the real crux of the matter: is the outward appearance of a person doesn't tell us what's inside their coronary vessels. And sometimes you don't know. You may have a Jim Fix type of person that runs marathons, looks fit, and drops dead of a heart attack. And then you might have somebody who might look like Winston Churchill, and smokes and is overweight and lives forever. So how do you know to apply the good therapies that we have? And there are good lifestyle therapies, which is my specialty. There are some nutraceuticals which are of benefit. There are medications which are obviously of benefit, and there are medical interventions. So we have lots of therapies, and we just need to know the degree of coronary artery disease, and the calcium scoring can do that. So the biggest premise is that we have lipid rupture or plaque rupture, and that plaque rupture can be microvascular, which means it doesn't break through this endothelium, this inner lining. So this would be macrovascular. And you can have microvascular ruptures, these little mini ones, and they eventually get walled off by calcium, and that creates more calcium in the blood vessel, or a stiffer blood vessel. So what happens is, this is how you get the calcium scoring. And as this process develops with these little microvascular plaque ruptures, you get a stiffer artery. The blood flows through it quicker, but it also can damage the artery more, and then eventually lead to maybe more injury to the artery, and maybe then a more macrovascular rupture. And the macrovascular rupture would be the soft plaque eventually ruptures in here. And you can have three different types of soft plaque. You can have a very inflamed lipid core. You can have a half fibrous, half lipid inflamed core, and then you can have a fibrous cap that goes over this. So when we do the coronary calcium testing, you get a score, and the score reflects about 20-80%. If you look here and you have this much of the score of the plaque, then this is about 20%. The soft plaque may be 80%, even though we can't see it unless we do CT angiography, but you can get an estimate of what's happening in here. So the goal is this, is that you want to, number one, identify how much coronary calcification someone has. And then there are different steps to intervene, from scores from 0 to 10 to 10 to 100, 100 to 400, and etc. And there are stepwise interventions to do. So first you want to assess that. Then two is, if you repeat a coronary calcium score, and you wouldn't repeat it unless maybe in a year at the earliest, you can see if you've stopped the progression. And if you've stopped the progression, that's good. Usually the calcified plaque doesn't go away, but maybe you stop the progression. And that's what you want to do at first. Now, why would you do this coronary calcium scoring versus CT angiogram, which you can actually go inside, you do the same exact test, the exact same machine, you just put dye in, and it takes about the same amount of time, and you can see the different types of soft plaque. Why wouldn't you do that all the time? Dr. Budoff says it's not really necessary. Then there are two different reasons. One, this is a prognostic, a risk factor for coronary artery disease. The other is a diagnostic test, the CT angiography. If you had chest pain, you want to find out if it's cardiac or not. And that's one way you can do it. In fact, in many aspects, it's better than a traditional 2 two-phase or two-dimensional angiogram, which is black and white. Unless you want to put a stent in, then you have to use that type of invasive angiogram. So Dr. Budoff has championed this. He's one of the world's experts at doing this technology and interpreting this technology, and I see him teaching fellows and other physicians all the time on how to do this. And he has what he calls the ABCs, and I'm going to go over them with you. And they're his ABCs. So when somebody has coronary artery disease, the first might be you'd give some aspirin, low dose 81 milligram aspirin. 2 is you want to control their blood sugar, or B, control blood pressure. C is you want to lower cholesterol. He does believe in the statins. He does use CoQ10 if he feels that the statin is having a side effects like myalgias or whatever. But he still thinks statins are of value in reducing the bad cholesterol LDL, and he still believes that LDL is a bad player. And triglycerides as well in coronary artery disease. Diet, he's very positive on the Mediterranean style diet with fish consumption. And then exercise feels is very, 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 very important. And then the F would be fish consumption, but he says, you know, it doesn't feel like we eat too much fish in this country, and he's a believer in that the fish oil studies may come through, especially with the study that's going to use a strict 98% EPA, and there's studies ongoing, but that's not definitive as of yet. The last part may be garlic. He has done some studies on aged garlic extract, reversing some of this soft plaque. So for me as a clinician, one of the things I'm excited about is now I understand this much better, the coronary calcium score, but also I look for these inflammatory markers. So a coronary calcium score wouldn't be done like in a month. Think of it as think of atherosclerosis as like bone density or building of bone. So when you assess bone, you do a DEXA test, but you can't repeat that DEXA test in 2 months to see if your therapy is working. We do what's called N-telopeptides. It's a marker of bone breakdown. Well, likewise, here you could get a score of coronary calcium, but what I would do is test for these 2 inflammatory markers in particular, myeloperoxidase and LPPLA2. These are enzymes released from the plaque. To my understanding, myeloperoxidase is more relates to the top of the plaque. Is it going to break open like a volcano? And LPPLA2 is like if there's active atherosclerosis going on in the soft plaque. So that would be like the lava inside. So if those are assessed, so let's say you do initial coronary calcium score, and then you do a baseline of this and you get it down by diet, exercise, whatever you want to do, then these enzymes come down, then you've cooled off the plaque hopefully, and then hopefully a fibrous cap will grow over, or you regress some of the soft plaque. You can regress some soft plaque. It's really hard to regress the calcified plaque. And then you would maybe repeat the CT or calcium scoring a year later. But you could do these truthfully every couple of months. I've done them on patients and seen them drop within a couple of weeks of going on a very anti-inflammatory diet. So the moral of the story is the coronary calcium scoring is a very valuable technique of evaluating atherosclerotic risk and then applying the appropriate treatment. And I asked Dr. Budoff, you know, how do you tell of a good machine? And essentially it should be greater than 64 slices, because anything less than 64 slices is probably more than 10 years of age, and the technology doesn't give you a good picture. So the newer technology, the better the picture. And it can be read by technicians. It doesn't have to be read by a cardiologist, even though he oversees all the scoring and the reading of them. So I think it's an excellent tool to add to the armamentarium. I like the inflammatory markers as a way to assess, you know, what you're doing at the moment. And this could be done on a yearly basis. And if you want to do CT angiography, you could do it just out of interest to see if you have the soft plaque or the more vulnerable plaque. But that is really a test to determine chest pain's cause. Is it cardiac or is it some other reason? So my name is Kirk Hamilton. This is Staying Healthy Today show. Please listen to Dr. Budoff's interview. He does, you know, obviously a much more eloquent sharing of the information that I can do at this moment. But it's a good technology that can be done. And oh, by the way, the cost should be under $200. In fact, the goal is to stay under $150. And that's very reasonable. Sometimes Medicare pays for it, sometimes it doesn't. Private insurance don't pay for it. But as a screening tool, it'd be a great motivator, and it can delineate who we really need to help as soon as possible. So my name is Kirk Hamilton. I thank you for listening, and there'll be links below this YouTube to the podcast and other resources. I'll talk to you soon.